You're listening to the Blood Bank Guy Essentials Podcast, episode 036. Hey everyone, this is Joe Chaffin. Welcome back to episode 36 of the Blood Bank Guy Essentials podcast. I have what I think is a really exciting and interesting episode for you today. But before we get to that, there's something I want to remind you of. I shared the last episode 35, that bbguy.org and transfusionnews.com, while they're staying separate and independent entities, we've joined forces to bring you what we hope is the best possible combination of transfusion medicine, educational content, and current news. Way back when I started this website in 1998, I wanted to keep you up to date with current transfusion news, and it's just too hard for me to do all of that. Well, the folks at transfusionnews.com are already doing that, and so we're working together. They're a great site that gives you the latest news in blood banking and transfusion medicine, and you can also sign up there for the transfusion medicine question of the day, which I really recommend that you do. Now, as of right now, you can find my latest podcast episodes on the Transfusion News homepage, and you can find their latest news updates on my bbguy.org homepage. So this fall, though, we plan to launch a new educational feature that I really think you're going to be excited about. I can't really tell you everything yet, but it's going to fulfill one of the most common requests that I receive about this podcast. So I hope that you'll check it out and stay tuned. And by the way, you should know that Transfusion News is made possible by support from Bio-Rad Laboratories. Okay, so back to today's topic. Like I said, I have a great topic, and I have two great guests today. Just by way of introduction, you should be aware that over the last 10 years or so, the world of trauma transfusion has undergone what I would describe as really nothing less than a revolution. Certainly, we've all heard, well, I hope you've all heard anyway, about the famous 1-to-1-to-1 ratio of platelets, plasma, red cells that has kind of become the standard of care in massive trauma transfusion. And you can hear about that in previous episodes that I've done, such as episode 007 and episode 033. So double check those and be sure that you're up to date on that. But anyway, one of the dirty little secrets of this whole situation is that because we're using more plasma than before, and that's been shown to be true, by the way, in the studies, we have come into a situation where we are getting it's getting hard to keep up with the demands for group AB plasma in particular. And think about that for a second. I hope you would know AB has traditionally been considered the so-called universal plasma to give when you don't know someone's ABO type. That's, again, pretty standard transfusion medicine practice over the years. And that's, of course, because AB plasma does not have anti-A or anti-B. But because of the increased need to have more plasma, and not just have plasma, but to have a lot of it readily available quickly, we are really struggling in blood center world to keep up with the plasma needs in those situations. Unfortunately, no matter what we do, only about 4% of the world are group AB, so despite the fact that we try to keep our AB donors donating as often as possible, it's become a real significant challenge. So all of that brings us to about where we were a year or so ago when I wrote a blog post about this very topic. And you can find that blog post on my website, bbguy.org/blog, and you can find a blog post about Group A plasma in trauma. So as we'll discuss in this episode, a lot of places have already moved to the use of Group A rather than AB plasma for trauma and emergency transfusion. And that was mostly based on data from a few articles, but not a lot of data. And I think the question that has not yet been answered, at least up to this point, has been, how safe is this? In other words, those Group B and AB people that get Group A plasma, what happens to them? And that's a really, really important question. And today I have as my guests two physicians who are lead authors on papers that actually describe the safety of those Group B and AB patients who get Group A plasma in emergency settings. It's really, really important. And together, and these are two separate papers, but if you add them up and subtract a little bit for overlap, they have looked at a total of over 400 of those patients who actually received Group A plasma, and they've looked at outcomes, and that's what they're here to talk about today. My two guests, who are both outstanding physicians. The first guest is Dr. Nancy Dunbar. Nancy is an associate professor of pathology and lab medicine and a clinical assistant professor of medicine at Dartmouth, and she is lead author, along with another former podcast guest, Dr. Mark Yazer, of a paper that's called Safety safety of the use of Group A plasma in trauma. And their study is called the STAT, S-T-A-T study. And that paper, as of now, as of when I'm recording this introduction, which is August 2017, is in early view in the journal Transfusion. You can go to bbguy.org/036, and at the bottom of the page, I have a link to that very paper. So Nancy will be here to discuss her paper. And in addition, my second guest is Dr. Tait Stevens. Tait is an associate professor of pathology and lab medicine at the fabulous Loma Linda University. I say that, of course, because it's my alma mater. Tait is the director of transfusion medicine and the histocompatibility lab at Loma Linda, and he is the lead author of a paper that's called Incompatible Type A Plasma Transfusion in Patients Requiring Massive Transfusion Protocol, and it's the outcomes of an EAST multi-center study. We'll explain what EAST means during the discussion in a few minutes. That paper was published in the July 2017 Journal of Trauma and Acute Care Surgery. These doctors both have a lot of great things to say, and I'm really looking forward to you hearing what they have to tell us about the safety of this. So, without further ado, here's my interview with Doctors Nancy Dunbar and Tait Stevens. All right, welcome to the podcast, Nancy Dunbar. How are you?
I am well, thank you.
It's great to have you here. And my friend Tait Stevens, how are you, Tait?
Good morning.
Good to have you both here on the podcast. I'm really excited about this because you both have kind of coincidentally published papers or are in process of publishing papers that answer some really, really important questions for us about the use of Group A plasma in trauma settings. But before we get to that, I think it's important that we kind of set the stage for where we're going with this. And Tait, I wanted to start with just a quick question for you. And I'm wondering, from your perspective, what's changed about plasma transfusion in trauma settings in the last 10 years or so? Why has this become a bigger issue for us in the blood bank?
So in the last 10 years or so, we've seen a more acceptance of the idea of using Group A plasma for resuscitation, I think in part because there has been shortages of AB plasma throughout the country. I think we've all had the experience of having somebody who needed, daily exchanges for weeks and weeks who was an AB plasma patient, and so you didn't have AB plasma on the shelf. So people use A plasma sometimes, and it seemed to work, and it is available. With 5-day pre-thawed plasma being available, we can give immediate plasma resuscitation to patients coming in with massive trauma. Getting that plasma early is really important. There's a couple of studies, I think Proper supports the idea of early plasma. There's some other studies they cited that also support that. So thawed plasma is really a major advance in trauma resuscitation, but AB plasma just doesn't make sense in that setting.
Okay. Well, so Nancy, I guess to someone maybe just starting in the field, it may be a little hard to understand. Why can't we just give people ABO identical plasma from the second that they roll into the trauma room?
Well, I think the challenge is really both an inventory availability and inventory management problem. So it's great if you happen to have the luxury of having an unlimited supply of plasma that you can keep thawed at all times on the shelf for the next trauma patient who may require resuscitation. Just from our perspective at my medical center, we're a rural trauma center and we don't get trauma patients every day. So just maintaining a thawed plasma inventory logistically is hard because we have to continually rotate it. As Tait mentioned, it's a 5-day shelf life. So about every 4 days, we're taking the plasma currently thawed on our shelf and redistributing that to other patients. The problem then comes with AB. There's a limited supply. So constantly having AB plasma on our shelf when it may or may not be actually used for a trauma patient means that we would be using a lot of AB plasma for non-AB plasma transfusions. And that's where the motivation to consider other options really became apparent for us. The alternative, if you don't keep thawed plasma on your shelf, is you really do have to wait for half an hour to thaw the type-specific plasma. And in a trauma situation, that time difference may not be ideal for a patient who may be getting, 10 or 20 red cells in that 30 minutes while you're waiting for the plasma to thaw.
Right. And I think that's a really important point that you guys both mentioned there. It's trauma transfusion has changed, and the use of the 1-to-1-to-1 so-called ratio is pretty much dogma at this point in trauma transfusion, and so people are demanding, for I think fairly reasonable reasons, to have plasma available the moment that they walk in the door. So we've got a problem with AB in terms of there not being enough of it. So Tait, you mentioned that there was some discussion about using Group A previously. Well, I mean, why would that be okay? That just kind of goes against everything that we have taught for years in blood banking. You wouldn't take, under normal conditions, a unit of Group A plasma off the shelf and give it to, say, a Group B or an AB person. Why is that okay in this setting?
I think there's a couple of pieces to the answer. The first one is somewhere around 85% of the time, it probably doesn't matter a whole lot because the Group A plasma is going to be compatible. Between Group O and Group A patients, Group A is compatible with the majority of patients. So we're really looking at that remaining 15%. And the question is, how often is that 15% a problem? And the answer is, we wanted to find out.
Gotcha. Well, I mean, is there anything about Group A plasma that well, you mentioned the compatibility thing, but is there anything about the whole process that might make at least people hypothesize some choices for why, or some opinions, I should say, for why Group A might be okay?
Well, I would just say that we do have experience transfusing patients incompatible plasma. Historically, we have had to transfuse patients incompatible platelets all the time, simply because with their 5-day shelf life, it's not always an option to give ABO identical or even ABO compatible platelets. Mm-hmm. So there's quite a lot of literature demonstrating that transfusing Group O platelets is most of the time safe. There are reports of hemolytic transfusion reactions with incompatible platelets, but thus far, all the cases that have been reported have been in Group O platelets. Mm-hmm. And we do know that Group O donors have higher titer anti-A and anti-B antibodies than Group A or Group B patients have for their respective antibodies. So there is some scientific rationale outside of plasma transfusion that also supports this practice.
So Tait, just cutting to the chase, do we have any data before these two papers that you guys are putting out? Has anyone else reported on this historically, on the use of Group A plasma in trauma settings?
Yes, there have been a number of single center studies with smallish numbers of patients getting out of group plasma, and the data from those look promising. But again, single center studies are limited in numbers of patients they can address.
Okay, and Nancy, wasn't your center in one of those centers that had reported a single center study?
Yeah. So our first paper really was more of a just a description of how we came to reach the decision of using Group A plasma, just in terms of the risk and benefit and our own challenges as a rural trauma center in supporting our trauma patients. So we didn't really report outcomes. It was more of a discussion of what our options really were and the pros and cons of the various choices available to us and how we decided to move forward with the Group A plasma thawed inventory.
Well, I'll give this last question before we go into the individual papers to both of you, and I just am curious about your perspective on this. So we have you mentioned we have some limited individual center studies. Do we have any perception, and Nancy, you can start with this answer, and Tait, you can follow up with your perspective as well. Is this happening already? Are centers across the United States and maybe around the world, but in particular in the United States, are centers already doing this?
Yeah, so the first thing we did before we did our own study is we asked that very question. We wanted to know how many people are already doing this, because I knew small rural trauma centers like Dartmouth and others that had published their own single center experiences were doing this, but I wasn't quite sure. We didn't know whether larger urban centers maybe, may also be having the same challenges and inventory constraints. So the first thing we did is a survey of level 1 trauma centers in the US, which we published, which showed that the majority of trauma centers that we surveyed were maintaining Thawed A plasma inventories and were using that for patients of unknown blood group.
Tait, did you find something similar as you guys were taking a look?
Yeah, we had our personal experience, our center's experience is that we had been looking at the idea and found some support for it, and had just pulled the trigger on moving to Group A plasma for initial resuscitation. And then shortly thereafter, the survey came out describing, I have Nancy's paper up in front of me. It says that 63% use Group A plasma in the initial phase of resuscitation of patients of unknown ABO group. That was, I think, from data in 2015. So we were very comforted to see that was not an uncommon practice, because it is a little bit different than what we're used to, and something that we had some concerns about.
Understandable. All right. Well, Nancy, let's start by going through your paper, and Tait, we will come back and go through yours in just a few minutes. Tell us a little bit about how this study came to be and how you guys put it together.
Yeah, so we were somewhat of an early adopter of Group A thawed plasma. Prior to switching to that practice in 2012, we were thawing on demand. And if the patient's ABO group was unknown, we were using Group AB plasma. And what we observed is that just the turnaround time for the thawed plasma was really not acceptable for trauma patients, because we were seeing an early plasma deficit, meaning patients were getting too many red cells before the thawed plasma was available. So we opted to switch in 2012 to the use of Group A plasma for all trauma patients, regardless of their ABO group. And when we made that decision, we were very curious to know whether other centers were moving in that direction. And around that same time, I think there was also an anticipated constraint on the AB plasma inventory that was coming as a result of changes in donor testing related to trolley mitigation. So we anticipated that other centers, maybe even larger urban centers, might be feeling some inventory constraints. So we started with a survey, which we previously published in Transfusion, and we used that survey to identify centers that were already using Group A plasma for patients of unknown ABO group, and we invited them to participate in a retrospective study, sharing their A and B and AB patients to compare mortality in trauma compared to what would have been predicted based on their injury severity.
And what specifically, as you looked at this, as you looked at these patients retrospectively, what was your primary outcome? What were you trying to determine?
So we were trying to determine whether there was an increased rate of mortality in the patients who received incompatible plasma, so the B and the Group AB patients, whether their overall mortality was higher than the Group A patients who received identical plasma. And we were comparing the mortality predicted based on their TRIS score, which is a trauma score that is assigned at presentation, and it incorporates their age, their mechanism of injury, and their injury severity score to calculate their overall odds of mortality. So we took the predicted mortality based on the TRIS score, and we compared it to their actual mortality to determine whether the B and the AB patients were having any observable increased mortality associated with the receipt of incompatible plasma.
Okay. And you may have mentioned this. If so, I missed it. I apologize. How many centers were involved in this study?
So we were able to recruit 17 centers that were willing to participate. There were certainly other centers who were using Group A plasma that opted not to participate for whatever reason. 16 of those centers were in the United States, and one was in the UK.
Okay. And how many patients are we talking about that you guys ended up looking at?
So when we did our power calculations, we needed in the ballpark of 300 to 400 patients in the incompatible group to to show a 10% difference in mortality, and we were able to obtain data on 354 patients who were who were B or AB. So there were 354 patients in our incompatible group, and then our identical group, the group A patients, had 809 patients. Of course, group A blood type is much more common than B or AB, so we had many more patients in the identical group.
Got it. Now, one thing that I think is perhaps a little easy to, well, I shouldn't say it's easy to miss because you guys specifically state it, but I just want to get clear on this in your paper. When people are looking at the statistics, the numbers at first can seem a little confusing, but you guys excluded Group O recipients specifically. Can you talk about what the rationale for that was?
Yeah, so there are. It's appreciated among people who study coagulation that Group O people are different in terms of their clotting. They typically have lower levels of factor VIII and von Willebrand factor, so we're not all identical. And for Group O patients, Group A plasma is neither identical nor incompatible. So there's nothing on the red cells of a Group O patient that's at risk of hemolysis from Group A plasma, but there is soluble A substance potentially in the Group A plasma, and we didn't really know whether that could be a potential confounder for the Group O recipients. Mm-hmm. So we chose to exclude them. And again, we knew we would have plenty of A patients to be our comparison group just because the population frequency of the Group A blood type is so much higher.
That makes sense. I just wanted to make sure that was clear to everyone taking a look at the paper. Well, one thing before we get to your results, I'm curious about this. When you looked at those 17 centers, and I'm going to say this tongue in cheek, and I'm sure you'll understand where I'm going with this, but I'm sure that what you found is that all the centers were using exactly the same protocols in terms of doing titers and limiting amounts and all that stuff, right? It was all the same, I'm guessing.
Of course not. It was totally different. And, we didn't even ask about the contents of the protocols because we know that there is some variability in terms of what gets sent in, what ratios, what goes first, whether platelets come with the first batch or not. We just assumed out of the gates that everyone would have different protocols. For inclusion in the study, the patients had to receive at least a unit of Group A plasma transfused. We did collect data on whether there was a practice to titer the Group A plasma for anti-B levels, and really only 4 centers required those units to be titered before they would dispense. Of course, they use different titer cutoffs. The majority of the centers, we were actually surprised to learn, didn't have a limit, so you could continue to issue Group A plasma until the type was known. Although some of the centers did have limits, anywhere from 4 to 10 units before they would switch to AB plasma if the type was still unknown. So of course it's very difficult, and of course we recognize too that the surgical techniques and all the other confounders exist when you're comparing centers to center differences. It's very difficult to standardize.
Of course. Okay, well, so don't keep us in suspense anymore. Not that it's you that's kept us in suspense. It's been me. But tell us, what did you guys find? What were the results?
So the first thing we found, and we wanted to make sure that our populations were comparable, and for the most part they were in terms of age and gender and all of those things. But we were surprised to learn, and I think Tait saw this also, that the patients in our incompatible group did have a higher rate of penetrating injury. So in that sense, the two populations were not the same, and I think that's important to keep in mind. But to cut to the chase, we didn't see in the two populations any observable difference in either their overall mortality, their mortality in the initial 24 hours, or their hospital length of stay. So those were the outcomes that we particularly were examining. And even though the groups weren't entirely matched in terms of mechanism of injury, there didn't appear to be a signal showing that the group B and AB patients who received incompatible plasma were dying at any increased frequency compared to what was expected based on their age, injury severity, and mechanism of injury.
So people that are listening to this, I'm sure, are going to be wondering this next question. In fact, it's the last one I'll do before I head over to talk to Tait about his paper. But what about transfusion reactions? What was and I recognized right up front that your primary goal here was not to look specifically at transfusion reactions. But what did you find about transfusion reactions from the group that you looked at?
So transfusion reactions are difficult because we suspect that they are probably underreported in general, and specifically in these situations where there's a lot of other stuff going on when you're resuscitating a trauma patient. But we did ask the study sites to submit data on transfusion reactions that were reported in the trauma patients using the normal reporting mechanisms at each site. And we were looking specifically to see whether there would be any transfusion reactions that were suspicious for a hemolytic process. But what we found is that there were, of course, very few transfusion reactions reported. More transfusion reactions actually in the identical group, which was a larger group of patients. There were no transfusion reactions reported in the incompatible group at all, actually. And the only hemolytic reaction that we detected was in the identical group, and it was actually due to a red cell antibody against the Duffy A antigen, which was not known at admission or maybe not detected until later in the resuscitation.
Okay, so Nancy, before I leave you and talk to Tait about his paper, is there anything else aside from the how does all this fit together, which we'll talk about at the end? Is there anything else that you wanted to mention about the paper that people should really be aware of?
Yeah, I mean, I guess in closing, I would say that in a perfect world, we would do this as a prospective study. We would randomize patients to receipt of incompatible plasma, and we would draw all the usual markers of hemolysis to really be able to see what's happening. But the reality is that those studies are very difficult to do in a traumatically injured patient, and so I'm happy we accomplished what we accomplished within the limitations of a retrospective study. We haven't definitively ruled out the possibility of hemolysis. All we've been able to show, which is something, is that it doesn't appear to increase the risk of mortality. So there's a lot of unanswered questions there. I don't think the book is closed in any sense of the word, but it's a beginning, and at this point in time, just given how challenging prospective randomized control trials are to accomplish, this is a contribution that I think it could reassure other places that might be considering this practice for whatever reason, for shortages or other decisions.
So Nancy, thank you very much for that great summary of your paper. I want to Tait, bring you back in and have a conversation with you about what you guys looked at. Now, your paper is called Incompatible Type A Plasma Transfusion in Patients Requiring Massive Transfusion Protocol, and it's the outcomes of an Eastern Association for the Surgery of Trauma multi-center study. And you're the lead author on this, along with a whole bunch of other folks. It's live as of July 2017 in the Journal of Trauma and Acute Care Surgery. So Tait, why don't you tell us the story of your paper and kind of how this came together for you?
Okay. Well, I should absolutely give props to Dr. Andrew Bernard for sort of putting this together. He had put out a conference call to members of the Eastern Association for Surgery of Trauma to talk about doing a plasma paper. And as I think I mentioned earlier, we're interested in following up on, the safety of the practice, because we felt like, we wanted to know what the data was like for the Group A plasma for massive trauma resuscitation. So we thought, this would be a great chance to get more data, better insight as to what's going on. So we were delighted to participate in that. So we put out a call, and the people that responded, that the institutions are listed in the paper. One of those of note is Martin Zielinski from Mayo, who had previously published one of the single institution experiences on Group A plasma use. So we had some insight from him as to how we might put this together. What we did is we looked at it's sort of a retro and prospective study. We looked back to a certain time point and then tracked through August of 2016, just as a convenience of putting the data together in time for fall and winter meetings. And what we did was we went back and looked at the records, and again, somewhat prospectively at times, to see what outcomes people had for plasma transfusions, comparing those that had type A plasma for resuscitation when that's incompatible versus those who had type A plasma for resuscitation when it was compatible.
Okay. And just to be clear, Tait, those categories, unlike in Nancy's paper, you guys did include group O's. Is that correct?
Yes. I think, the insight that led Nancy's group to exclude Group O makes a ton of sense, and I think that's a valuable thing to have looked at. I'm glad that data exists. We were really just looking at, hey, for those that use it versus those that don't, do we have difference in outcomes?
Got it. Okay, and so how many, between the 8 centers that you guys were working with, how many patients, what were the numbers that you came up with?
So overall, for all sites, we had 1,500 and some patients who presented to trauma. They had to be adults, so at least 15 years of age for adult trauma center participation. And we included everybody on whom a massive transfusion protocol was activated. I should mention, if they died before we got a blood type, we didn't know what category to put them in, so we did exclude those guys.
Sure.
And out of those 1,500, a total of 120 received incompatible type A plasma. That is, were of group B or AB and got plasma. That's about 8%, which is a little bit lower than you might expect given the overall numbers. But I'll point out a couple of the centers in our study didn't use a couple of centers are sort of controls. They use group AB plasma, so they contributed to the compatible but not to the incompatible group.
I see. Okay. And I should have asked you before I asked you the numbers, but what was your primary outcome? What were you guys primarily looking for to determine differences?
The question we were trying to answer is, does it make sense to use group A plasma for resuscitation? And, in terms of risk to patients and patient outcomes and that kind of thing. So in our early teleconferences, we had a brainstorming session about what can we look at that would be useful to assess whether this is a good practice or not. And that included certainly mortality, and I think we ended up using it multiple different time points. We wanted to use hospital length of stay, and we realized as long as we're in the charts, we can get out some additional length of stay, like ICU length of stay and how long we were on the vent. Mm-hmm. We also wanted to look at morbidity. Maybe the patients lived but didn't have, as good of an outcome. So we looked for some additional morbidities. And the ones that we looked for were largely ones that are coded in the trauma database. So it didn't require somebody to go back and manually re-extract from 1,500 patients, look through the entire chart looking for evidence. What we did was use the trauma registry data, which included ARDS, PE, DVT, pneumonia, sepsis, renal failure, and trolley.
Okay. And so again, let's have it. What did you guys find? What were your results?
Our results were that there was basically no difference. Again, as Nancy mentioned, the penetrating injuries are a little bit higher in the incompatible group, so that kind of makes it a little bit, that's the one area where it's not a apples to apples comparison. Right. But we found really no difference in rates of any of the morbidities and the length of stay, pretty much anything. With the exception of the incompatible group, ended up getting more plasma transfusion, and that's something we wrestled with understanding a little bit. It's not clear why they got more plasma transfusions. Maybe, we conjecture in the paper, maybe it's due to more group A plasma being available in places that use group A plasma for resuscitation. It may be that there's something intrinsic in the system. It may be that just as you look at a population and look at enough variables, sometimes something's going to just come out funny that isn't really there.
Gotcha. So no significant differences in the major things you were looking at. I'll ask you the same question I asked Nancy. What about transfusion reactions?
The transfusion reactions, again, we didn't look at all transfusion reactions. And again, as Nancy pointed out, transfusion reactions are not probably always fully reported. I suspect that if you really do prospective, active, maybe even use the word proactive monitoring for transfusion reactions, you're going to find more than end up getting reported. And again, we were using retrospective reporting. So the answer was there was no difference on the rate of transfusion reactions. There were 2 trolleys in the compatible group, no trolleys in the incompatible group. Otherwise, no ARDS, no difference in ARDS, no difference in anything that we could find.
Okay. And this is just an aside for both of you that it doesn't. I have to tell you, it doesn't surprise me that nothing was found with, I guess, what we would call passive hemovigilance. I published a podcast not long ago, a discussion with an emergency medicine critical care doctor, and I asked him specifically the question: when you're in the middle of all this in a trauma setting and you're doing a massive transfusion, how do you monitor for transfusion reactions? And he paused for just a second and he kind of laughed and he said, "Well, we really kind of can't. I guess if they got a rash, we might notice it or something." So honestly, it doesn't surprise me a lot that we didn't necessarily find anything. But I mean, I guess the important point, and I love the perspective of both of you on this, as blood bankers, we worry about stuff like this because it hasn't been the traditional way we've handled it. But the fact that nothing was glaring, I think that's at least somewhat reassuring. How do you guys feel about that?
It definitely for us, I feel like it validates our practice. I mean, I still believe that if we had unlimited resources, we would certainly do something different. We would give everyone AB plasma and then we wouldn't worry about it. But that isn't, unfortunately, the reality that we're in. So this is just yet another piece of evidence to help me sleep better at night and know that I might not be harming people in my efforts to help them.
How are you sleeping at night, Tait? How do you feel about that? In everything in life, certainly in medicine, there's trade-offs, and the trade-off is do we use group A plasma, which we know might not be perfect for some patients for resuscitation, and then not have AB plasma for times when we really actually specifically need it. How do you make that trade-off?
Yeah.
And the answer is you try to measure the risks as well as you can. Part of the trouble is that severe transfusion reactions are quite rare. Mm-hmm. And although we can try to do a power assessment, if you have a reaction that really happens 1 in 50,000 times or 1 in, let's say, 1,000,000 times, how many trauma resuscitation events would you have to evaluate to determine whether the risk is higher of a 1 in 1,000,000 event? I think that study is almost undoable.
Okay, I think that's a super important point. It's we're in a situation where we are limited by our population genetics, that only 4% of people are AB, and the demand is certainly greater than AB. And I can speak I'll put on my hat as a blood center medical director, and I can tell you that we in blood centers are doing everything we can to get as much AB plasma out there as possible. But for us, when certain trauma centers are looking at, wanting 20% AB supply, that's very, very difficult for us to manage. So this really is an opportunity, I think, for us to kind of overcome that population genetics problem that we have and potentially give something safer or at least as safe. And that's really, I think, kind of from my perspective, one of the big take homes. But I want to give you guys both the opportunity to really kind of big picture this for us. So Nancy, I'll start with you. In light of what your study has shown and what Tait's study has shown, from your perspective, where do we go from here? What if anything are the next steps for us to take?
Well, I think for our center, we definitely recognize that we're a lot more conservative than many of the other centers participating in the study, so we continue to titer our Group A plasma. We use a very strict 1 to 50 cutoff to consider it low titer. And we limit the number of units a patient can receive to 4. And I think, I was surprised to see that other places either don't titer or don't limit the volume or neither of those. So I think for me personally, the next steps are to continue to get at this question of whether we need to titer. And we're currently working on a multi-center study looking at centers who do titer and what the frequency of finding high titer units may be, just to answer that question of whether it's necessary or not. Like I said, I would love to do a randomized prospective control trial, but I just don't think in the current state of research funding and other probably priorities that's going to happen anytime soon. So I think it is what it is, and there's a few additional questions we're going to try to sort out with follow-up studies.
How do you feel about that, Tait? Do you think this is the best we're going to get, or do you think there's more work that needs to be done or will be done?
I can't add to what Nancy said. That was a very eloquent answer. I have a couple random stray thoughts which may be helpful. One, I do anticipate that we will see, maybe as abstracts, a case report or a couple case reports in the next several years of hemolysis due to Group A plasma use in resuscitation. And the question we'll need to ask ourselves is, okay, it can happen. We knew it could happen. It's going to be really hard to figure out what the risk is of continuing with existing practice versus, responding to that data. So that's something I think we're all going to need to ask ourselves. The other random thought is, it would be really, really cool if somebody came up with a way where you dropped in 1 or 2 drops of plasma on a stick, kind of like a pregnancy test, and it turned blue if it had a high enough titer that it was a problem for trauma resuscitation, and stayed clear if it was okay. Some kind of really easy way to titer. I have no idea if that's even possible, but for those listening, make a patent.
Very nice. I can see people scribbling furiously about their next research project as they're going forward.
Well, titers are not that easy to do, and it would be, really nice if it was sort of something that trauma centers were able to do and have units that were identified as low titer, that are maybe the first ones you would pick for a resuscitation.
Mm-hmm. Mm-hmm. Okay. Well, so again, let's make this as practical as we can. So I'll throw this question out to both of you. If you were in the setting, and I know you guys have mentioned you practice in somewhat different settings. Nancy, you mentioned yours is more of a rural trauma center. Tait, you're an hour away from Los Angeles, so you're not quite urban, but you're a major trauma center in your area, correct?
Yeah, I have been to Dartmouth. It's a beautiful place, and we're similarly somewhat suburban, but there's more sort of major freeways around and sort of violent activity and stuff. So we do get some rural stuff, but it's probably more characterized as probably suburban.
Okay, so I guess the question that I'll throw to both of you is: imagine yourselves in the situation that you will probably be in, since you're both, or you may have already been in this situation, because you both have put out you're both lead authors on these papers, and you both are considered thought leaders in this field, in this area. So someone calls you up and says, my center is considering this Group A thing. What would you tell them in terms of what they should be thinking about and your opinion on whether or not it's something that you should consider in massive transfusion settings? Nancy, you can start with that one.
Yeah, so I would advise them to approach it much in the same way we did when we were considering this decision at our own center. I think it's all about weighing risks and benefits, and I think in trauma populations, the currently available evidence does really support early provision of plasma being associated with improved outcomes. And I think if the only way you can do that is by using Group A plasma, then at least there now is some evidence. It's retrospective evidence, so it has limitations, but there's some evidence to show that at least with pretty crude outcomes like mortality, it doesn't seem to be obviously or apparently causing an increased risk of mortality in the patients. That's all we can say. But I think there's certainly rationale to argue that the risk is low, particularly when you're concurrently transfusing Group O red cells and basically replacing their blood volume with blood that's compatible with Group A plasma anyway. So I think it's just a question of what risk you're willing to assume. I do agree that it's possible there will be case reports, isolated case reports of hemolytic complications related to this practice. It's certainly plausible from a physiologic perspective that we could observe that, although, in the evidence we have available to us now, it appears to be quite rare because we have not seen it yet.
Okay, Tait, so put on your consultant's hat and someone calls you with the same question. How do you answer it?
I tell them to talk to Nancy. It's a perfect answer. I really have nothing to add to that.
So Nancy, you're getting all of Tait's calls. Is that okay with you?
Yeah, I think I may need to change my number. I won't get any work done just consulting for Tait, but...
No, but quite seriously, Nancy's answer was, I think, very complete. The only thing I would add is to maybe, point them to the published literature for example, by Dunbar et al., in which it, summarizes, 2/3 of the groups out there doing trauma resuscitation, even before these papers came out, were using Group A plasma. I don't think that number is going to go down as a result of these papers. So, I think it is a common practice. Whether it's the best practice, that's not yet provable, but based on the best available data, I think it's a very common practice and a good one.
Okay. Tait, I have one more question for you, and that is in regards to how this process should work. And let me be clear on what I'm asking. In that same interview with the trauma, the emergency medicine physician I was mentioning earlier, he mentioned that in his setting, one day Group A plasma just started showing up in their massive transfusion packs, and people were freaking out going, well, wait, somebody's screwing up. Do you have any thoughts on how to implement this in your hospital in terms of communication and communication in general in these settings?
The answer is yes. I am a member of the trauma committee. I was initially invited as a result of some things they weren't sure was whether right or wrong. So I was asked to come and sort of defend some blood bank practices and how things went. And as a result of the value of that discussion, they kept me on that committee. And we've had a number of good interactions. For example, that's the committee where I report on the audits of our massive transfusion use to make sure people aren't using it inappropriately. And at one point I told them, I haven't seen any inappropriate use in a couple of years. That suggests that maybe it's being slightly underutilized. So at that point, I think they realized I'm not the guy that's trying to keep them from getting blood. I'm a guy who's trying to make sure they get what they need and they're using it, in the best possible way. And so in that setting, that's where the idea of using thawed plasma came up. And it was at that time that we said, look, we can do thawed plasma, but if we do thawed AB plasma, we're going to end up chewing through AB plasma and won't have it available for patients who really, truly need it. What do you guys think of using Group A plasma? We looked at what information was available at that time. There wasn't a whole lot, but they did accept that. So in contrast to the interview that you were relating, I think having a conversation between the transfusion service directly with the trauma team makes a ton of sense.
Okay. Nancy, your thoughts on that and how did you implement it at your center?
Yeah, I definitely think you want to have a discussion with the stakeholders, make sure they know it's coming, make sure they're that they have an opportunity to weigh in. We also went through the process of formally approving this by the hospital transfusion committee, just to kind of make it clear that we acknowledged that there was potential risk, but we were willing to assume that risk. And we do have a special form that that gets sent with the Group A plasma that basically is like an attestation when you ask for emergency uncross-matched red blood cells. Like, this we're sending this to you because your patient is in need, but there's some risk that's associated with this that you need to accept when you order it. So we treat it much the same way that we treat emergency release of uncross-matched blood.
Okay, so Nancy, I had one more question for you as well on this, and that's, I don't know how best to put this, but we've talked today primarily about the use of Group A plasma in trauma settings. I've seen, and I'm guessing Tait has as well, I'm curious about your experience. Are you seeing people try to apply this to other, non-trauma type settings in your hospital?
Well, yes and no. So like I mentioned, I think we here at Dartmouth are fairly conservative. So the use of Group A plasma here at our institution is limited to trauma patients, and that's based on the fact that it's really only in the setting of trauma that the evidence supports early provision of plasma. But among providers who may be resuscitating an exsanguinating patient, those could be obstetric hemorrhages, they could be GI bleeders. Those people may not be as familiar with the evidence, and I often see people asking for one-to-one resuscitation in non-trauma patients, and I think the value of that practice is unknown. I think there's a lot of work to be done about different clinical settings requiring massive transfusion and what the best approaches may be in those settings. What I do in those settings is I am aware that we have thawed A plasma available, and I really make the decision on a case-by-case basis. Often medically bleeding patients, I know their blood type, and so if they happen to be a GI bleeder with a elevated INR who's, requiring massive transfusion, and I know that they're A or O, I might say, go ahead and send the emergency plasma because I know it's compatible for them. But we have not yet as a center extended that practice of using Group A plasma for Group B or AB patients outside of trauma yet.
Okay. Well, both of you, this has been a great discussion. I really, really, truly appreciate your time and your expertise. I think that both of you and the folks that you worked with on your papers have contributed something really, really important to the literature. So thank you both, not only for that, but for being here on the podcast today. Thank you so much.
You're welcome. Thanks for the opportunity.
Thank you for having us.
Well, as sometimes happens with episodes like this, almost as soon as I get people off the call, that I realize that there's one other thing that I wanted to talk to them about. So I just want to share something with you that to go back to something that Nancy mentioned. She mentioned in the survey that she and Dr. Yeaser and the Best Collaborative did, published in January 2016, that the majority of trauma centers do not limit the amount of Group A plasma that can be administered to patients. And in fact, in that survey, 62% of centers did not limit the amount of Group A plasma that was going in these situations. So I want to make something really clear to you, because I think this is really important if you are in the process of implementing this, or even if you've already implemented it. My perspective on this is that this Group A plasma that we're giving in these urgent situations is not intended to be a quote unquote forever product. It's not going to be the thing that you just keep giving. Remember, whether you're using thawed plasma, and that's Group AB or Group A, or if you're using liquid plasma, again, Group AB or Group A, my feeling in this is that that's a bridge product. In other words, you're trying to get that patient to the point where you're giving them a freshly thawed, hopefully ABO identical previously frozen plasma product, because that really is the best product for them in that setting. I don't think really many people would argue with that. So my perspective is, even though it doesn't seem like most people have limited the amount, and I'm not sure that I have a particular number. Dr. Dunbar mentioned that they limit it to 4, but it's incredibly important to make sure that people understand that, in particular, the trauma personnel understand that it is vital that we get a sample to get an ABO type on that recipient, so we can get that product. We can move it from that bridge that I was mentioning before to a very specific and really, really good product for that patient. So I just wanted to make that really abundantly clear. Okay, with that being said, I want to extend once again my thanks to Drs. Tait Stevens and Nancy Dunbar for appearing on this podcast. And thanks to each and every one of you for listening and for your feedback. Again, the show notes for this particular episode are at bbguide.org/036. Just go there and you can find the links to the articles that we discussed, as well as some other articles that we didn't get to during this podcast. And in addition, I read every single comment that's put on the website, and I respond to many of them, if not pretty much all of them. So let's have a discussion about this. Tell me how you feel about this. I think it's really important to discuss it. So that's it. Thanks again. And as we close, I hope that as you go through your day today, that you'll smile and have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.